Okay. Yay.
Hey. Well, good afternoon, everyone. Welcome to the National Cancer Coalition's Ask the Expert Facebook Live series, taking place the last Thursday of every month. My name is Jennifer McClendon, and I am the Education and Mission Program Senior Manager here at NOCC. And today we are going to be covering a hot topic in the field of cancer treatment, genetic testing and biomarker testing, commonly referred to sometimes as tumor testing. And this session is generously supported by Sophia Genetics. Today we are honored to welcome Dr. Buttin, a gynecologic oncologist at the Cancer Treatment Centers of America in Chicago. Dr. Buttin's practice is completely patient-focused as she centers her treatments on the individualized needs of the whole patient. And this philosophy fits so nicely into our topic today, as she will be answering questions for us in regards to individual tumor markers that help us individualize our targeted treatments. So it's great to have you with us today, Dr. Buttin. Thank you for your time.
Thank you for having me.
Absolutely. Great. The topic of targeted treatment and tumor testing to find those targets or those markers, we hope that will help us guide us in the right direction for treatment, is definitely a hot topic right now. And we know that there's a lot of movement. And I know that many of us are hearing how important it is for us to know certain statuses, certain biomarkers, and how they can relate to us, knowing what types of treatment are best for us. So I'm looking forward to hearing more about this today. So thank you for joining us. So hopefully maybe our first question might set up our discussion today. Before, one of my first questions was going to be, could you describe for us simply, if you can, I know it's a hard topic, but could you describe the differences between genetic testing and biomarker testing? But I thought it might be better to maybe start with just talking about or defining what a biomarker is in general. What's the basic definition of a biomarker?
A biomarker is basically a variable we can test, whether it be a blood protein or something we can test within tissue, cancerous tissue itself, that gives us a very specific fingerprint of a cellular process, or in the case of cancer, obviously, a fingerprint of what a tumor consists of, or what might give us an insight into what makes a tumor tick. How did it turn into a tumor? What are some of the mechanisms that have led to this abnormal growth? How does it come about? And the more of those abnormal mechanisms we can understand, and the more biomarkers there are that we can measure that correlate with an abnormal process, the more of an opportunity we have to target these processes, correct them, and thereby then treat the cancer.
That makes sense. So it's kind of giving us an insight to how tumors behave, right? So we know how to better manage them. Okay, I love the way that you explained that. That's great. Thank you. So now that we have that kind of established, can you kind of talk us through the differences between what we hear about genetic testing, like for an inherited mutation, and then what the difference is between that and biomarker testing?
Absolutely. Genetic testing, I think is a really hot topic today. I remember the days not too far in the distant past, when we had to really try and convince patients, families to consider genetic testing, because everybody was afraid that if you have an inherited, mutation or some condition that was linked to an inherited problem, that you would lose your insurance or your benefits, or you would start paying higher premiums. And everyone remembers those days, and it was a really scary time. Luckily, that is completely behind us. There's legislature in place now that really protects patients from any sort of genetic-based discrimination. And Genetic testing has become widely available,
Mhm.
and it really changes what we do for patients, both in terms of I would say first and foremost in terms of prevention.
Right, right.
When we talk about cancer prevention, right, understanding that you may be born with an abnormality in a gene that
Mhm.
predisposes you to getting cancer, right,
Yeah.
can
Mhm.
open the door to a host of interventions that can help you remain healthy and cancer-free,
Right.
and lead your life in accordance to that knowledge. But then, even if we have someone who, God forbid, already has a cancer diagnosis, even then you might say, well, the cat's already out of the bag. Why would I care if I have a genetic
Right.
or not? But even then, it is important to understand how or what factors may have been responsible in you acquiring that cancer. And if there is an inherited component to that process, not only would your family want to know that, your other blood relatives, right? But there are also then therapeutic linked interventions to certain genes. And therefore, it is a really, really important thing to do, even if you're someone who is in your 70s and already has had 2 cancer diagnoses. You might say, well, that's water under the bridge for me. Maybe, maybe not.
Yeah.
Right? There can still be insights to be gained that can help you fight your own battle, and certainly your extended family will benefit from the knowledge.
I
So
love the way you said that, the insights to be gained. There might be some genetic alterations that we didn't know of before that could inform how you move forward with treatment. I love the way you said that.
exactly. And the other thing I always point out is that patients think that if they have a genetic abnormality, or basically, what it means is that you're born with a variant of a gene produces an abnormal
Mhm.
protein, right? All genes basically produce proteins that are participating in various processes in the body. And if those proteins are dysfunctional,
Mhm.
they're not working the way they're supposed to work, they're either not working properly or they're absent altogether. And obviously, they all have a purpose somewhere. They're all needed for something. And if it's a very important protein and it is either not working right or absent altogether, then things are going to go wrong
Go wrong.
in
Yeah.
your body.
Mhm.
Now, does that mean that every person with an abnormality in a gene that has been associated with cancer is going to get cancer? No.
Right.
Right? That's important to realize, right?
Sure.
Just because you have an inherited predisposition to developing cancer still doesn't mean that risk 100%.
Right.
Good God. Thank God it can't
Yes.
be. But if it is even as high as 40% or so, I'd say that's a significant risk, right? That I would want to know about.
Yeah, absolutely.
When we're talking about something as rare as ovarian cancer, remember ovarian cancer, the risk for someone developing that in the general population without any predisposing factors is only a little over 1%.
Mm-hmm.
And if you're born with a mutation that may predispose you to getting ovarian cancer, it simply means you are that much more likely to get it. Not doesn't mean you will definitely get it, but you are
Yeah.
that more likely to get it, that your risk all of a sudden is as high as 44%.
Yeah.
But that
Mhm.
is a dramatic difference, right?
Yes.
I think
Yeah.
that's where genetic testing can make, big differences in how people plan their lives. When it comes to reproductive cancers, of course, how people plan their reproductive lives, maybe their
Mhm.
their family planning, how many kids, how early, when they may want to,
Mhm.
deal with fertility versus career and all of those choices that we make somewhere along the way. So
Yeah. Yeah. Thank you so much. So to make sure I understand correctly, that looking at these genetic mutations can help not only inform your risk in the lives of your family members, your family members, but also knowing what genetic mutations someone may have after they're diagnosed can help inform treatment. So it's used in two different ways. Is that
that is
correct?
that is correct.
Great. I understand. Okay. It's a hard concept.
Used to it.
Yeah.
Whether or not you already have a diagnosis of cancer, or you're someone who's 20 years old, but has a mom and a grandma, perhaps, with a history of cancer, and you wonder what your risk is and what you can do about it. It is helpful on both ends of that spectrum.
Great. So for someone diagnosed with ovarian cancer, going through trying to decide, they're talking with their physicians and deciding on the best course of treatment for them. So there's genetic testing, but then there is what you've already kind of discussed, biomarker testing. And really the difference between those two is?
Right. So I always say genetic testing looks for variations in the genome that you were born with, that each and every one of your cells has. Genomic testing, which is the other word for biomarker testing, is basically looking for acquired abnormalities in genes that have only happened in the cancer cells, right?
In the cancer cells.
Something has happened in those cancer cells that makes them different from your normal cells, right? Yeah. They're growing out of control. They've lost all control. All sorts of things are happening there that are not happening in every single cell in the body. So now we're in this era where we can easily take a little piece of cancerous tissue, extract the DNA, which is the genetic material from those cells, and sequence it or analyze it for mutations, just the way we analyze our own genome, our whole genome, when we're looking for inborn mutations.
Inherited, got it. Okay, so looking at the actual mutations of the tumor itself.
Exactly. So in other words, you may not have been born with a mutation in a BRCA gene, but your tumor might have acquired one. Might have acquired one along the way, and ends up acting just the same as a tumor from a person who was born with the BRCA mutation, in the germline or from birth that they have in every cell.
Okay.
There's always more than one hit, obviously, to cancer. So just because a person is born with one defective copy of a BRCA gene, again, does not mean they got cancer, but it brings them one step closer. Right?
Yes.
So then two more things happen along our lifeline, and that cell will turn into a malignant cell that much sooner, right? Perhaps in the person who was born with the abnormality. But the person who is not born with the abnormality can still go down that same exact path, maybe a little later in life, maybe it takes a few more hits to the cell, but the end result can be the same. And that is what we can measure with genomic testing, mutation testing, right? And biomarker testing. That helps us categorize almost half of all women with ovarian cancer into those folks with tumors that act along the lines of a BRCA mutated cancer.
Okay, interesting.
Right. So only 20% or so of those are going to be related to inherited mutations. And almost 30% of those are going to be related to acquired mutations in the same gene or family members. And genes come in families too, just like
sure.
So there are various family members of the BRCA gene family that do similar things and can lead to similar outcomes. We can measure with one or two biomarkers, right? We now have the ability to categorize cancers and say, this is going to be a BRCA-like cancer.
Okay.
Right. I think that's what we're going to probably talk about. That hot button term, HRD.
I was going to ask. I was going to ask you, what are some of the you know, we have a very smart group of survivors and patients that we work with all the time, and they know these terms and they're hearing these terms. And so we get questions about what is HRD or what is HE4? What is, you know, what does this mutation mean? And all. So can you, or do you think it would be helpful to kind of maybe review what some of the common biomarkers are that we may hear about for ovarian cancer?
Yeah, you know, so we keep talking about BRCA genes because
Yeah.
really those are not just the most common genes that lead, you know, when deficient in from birth, that lead down the path of someone developing ovarian cancer. But then the reason that is the case, we could also say, is that those are members of a family of proteins in the body whose function it is to repair a certain defect in our DNA.
Mhm.
Now, what do we need those repair proteins for? We need them every day, right? As we live and repair ourselves and grow ourselves, and every time that happens, you grow a new skin cell, a new anything, anywhere at all. Our entire genome within that cell has to be duplicated, replicated, remade, checked, double checked, proofread,
Yeah.
and then released. So it's quite a process, really, right? Keeping the genome intact, and ultimately errors are made, which of course has to do with the fact that we don't live forever.
We don't live forever, right?
Are made along the way of replication of our genetic material. Most of them, though, get caught by proofreaders, and we have all sorts of built-in checks and balances that will help out. And ultimately, if a cell has too many mistakes, then that cell should not survive, right? Because if it does and it has too many mistakes, then that could turn into something like a cancerous tumor, right? Like an uncontrolled growth, because, you know, it doesn't have the signals anymore that tell it to stop growing when it's a certain size, etc. Right? And so the BRCA genes, proteins that come from the BRCA genes, are involved in that type of process, repair process. And so people are born with a defect there. They have difficulty repairing cells, which is not so great for normal cells, but it's sort of something that we sort of want for a cancer cell.
For a cancer cell, yeah, you don't want a cancer cell to repair itself, right?
You don't want a cancer cell to repair itself. That's kind of like, hey, that's something we want to exploit, right? That's a good thing. And so, of course, you know, a lot of targeted therapeutics have been developed, right? And, you know, the term that everyone in the ovarian cancer world is familiar with, the term PARP inhibitor, was born out of that, the science behind what BRCA genes do. And so if we have cells, cancer cells, that have a weak spot, an Achilles heel, what do we want to do with that Achilles heel? Step all over it, right? We want to really hurt that cell even more when it's down, and try and kill it and not let it repair itself. Yeah. And so that is one of the most important things that we can take advantage of by treating that weak spot. So HRD, or homologous recombination deficiency, is the process, right, by which a cell can be deficient in that repair mechanism, And the protein PARP is a player in the family of proteins that helps with that repair process. And people who are born with abnormal BRCA genes have that defect. Okay, they don't repair cells the way they should, or at least one of their genes is a little impaired. Usually we have 2 copies of every gene, so that doesn't manifest as a problem day to day. But when you have a cancer cell, again, there could be a weak spot there. DNA repair is out. And so that can be measured, right? So scientists have really found this, the way of measuring the end product of what it looks like when a cell can't repair certain breaks in the DNA, and the way that can be detected is sort of a catch-all term, right? There are various mechanisms within that family of proteins that could be out leading to the same end result, that the cell can't repair these double-stranded DNA strands. And that process and the way it's measured in the laboratory is called HRD, right? So this is the end product of someone having been born with an abnormal protein, or a cancer having acquired an abnormality in a BRCA gene, even though you were born with two normal ones, or a cancer having acquired an abnormality in another BRCA associated gene, right? Because again, it's a big family, like a big Italian family. So there's lots of aunts and uncles. And there may be abnormalities in all kinds of people there in that family. But the end result of what happens to the cell is the same. It is deficient in homologous recombination in that process, right? And as long as we measure that, we know the cell is going to act the same way, or close, you know, I'm simplifying a little bit, but close enough, similar enough to the cell that comes from a person with an absent BRCA protein altogether from birth. Okay, so it's a measure of that particular process being out. And the reason we want to know if a person has that or not is that they're then going to be really, really great candidates for PARP inhibition, right, for those drugs. You don't have to be born with the mutation to be a good candidate for those drugs. You could just have a tumor that has HRD, right, through one of those processes, and you would be just as good of a candidate for those drugs, because those drugs help that process complete itself, right?
Right. Yeah.
The cells can't repair.
One of the questions, I usually hold questions to the end, but one came through that I thought would fit really nicely here is, do all tumors express markers? What if they do not express markers? Can you still get targeted treatment? Does it make treatment harder? I thought that was an interesting question. Do they all express markers of some sort?
Excellent question. And
it is.
We were kind of chatting about that a little bit right before we went online, because the answer is no, right? 50% or so of tumors do have this mechanism and express this this KS marker, you know, but then the other 50% don't. Okay.
Have any markers at all?
There are others, you know, there are other markers of other broken processes that we look for, because there are various processes that can be off, you know, in the repair process of the DNA when a cell has to replicate. And it's usually, you know, cancer is usually associated with one or another process that's broken, right?
Broken,
where it should stop replicating, but it continues to replicate because some signal isn't being heard or isn't being translated properly. So there is several other pathways besides HRD that are also being measured when that genomic testing is done. You know, some of the buzzwords there would be mismatch repair. Deficiency can be another pathway.
Is that another marker?
That is a marker, right?
Okay.
That is a marker of another pathway that can be off, and that multiple other proteins are involved in, et cetera, and that can also be targeted in different ways. So, but then there are cancers who just don't. They don't express anything that we can get our hands on. You know, they just don't have any of these changes that we now know about and that we can target and that we can do something about, you know, and you ask, what then, right?
Yeah.
And we still apply targeted treatments to those tumors. And the answer is yes. Okay, the answer is yes. There is always some overlap, Okay. Sometimes
Okay.
a cancer may have just a very minuscule amount of HRD, too small to measure.
Okay.
But the reason we assume that that is the case is because in the clinical trials that led to the approval of all of these wonderful drugs, there was obviously always some patients included who did not have any of the biomarkers that
Yeah.
we associate with a response, but they still had a response.
They still had a response.
They still had a response. And so, you know, it is not a complete lock and key mechanism. You must have the key fitting into the lock, then the treatment works. Otherwise, it doesn't.
Got it.
There is definitely some overlap and still, you know, still many unknowns.
Okay.
Don't want it to
Well, that's good to know.
we understand it all. But so yes, even when the tumors don't express anything at this point that we can measure, there is still the possibility of them responding to our targeted treatments. Yeah.
Great. Okay. So is biomarker testing something that someone's physician or their gynecologic oncologist would just automatically do when they're looking at their tumor? Or is it something that a patient must request or be informed about and ask about? Or how does that process work?
Well, first of all, I'm always a big advocate for patients
Mm-hmm.
knowing about testing.
Yes.
And yes, ideally, every gynecologic oncologist should offer genetic testing.
Sure.
So that is blood testing, right? That's a blood test looking for what you were born with. And that is truly standard of care. That is what every woman with ovarian, fallopian tube, or primary peritoneal cancer should be offered, because the incidence of these, you know, measurable mutations in the genes that you were born with, in the germline, we call it, is so high, you know, 30%. I mean, that's one of the highest incidences of any cancer. So that's offered to absolutely everybody. And then there's a little bit of a decision tree, right? If we know that you have a mutation and it is in one of those family of genes, right, in the homologous recombination pathway, then we're good. For the moment, that would be all we need. Okay, so you can go with that. That's going to help, you know, dictate what treatment is best for you in the beginning, right? And into maintenance, right? And so through chemo and into maintenance, into remission and into maintenance, that pretty much tells you that you're a good candidate for a PARP inhibitor and which one and all of those things. Now, if your genetic testing is negative, all that means is that you don't have a mutation that we know of.
That we know of, yeah.
You may have something, but at this point, we don't know. Then we need to go to the next step. The next step then is tumor testing, right? Because we know that there's another 30% of all the ovarian cancers out there that will act like a BRCA-dependent cancer. And so we're going to look for HRD. That really has to be standard of care as well.
I've heard that recently, yes.
That really should be standard of care, next step. And some of the genetic testing, the companies that order genetic testing literally have kind of a combined test, you know, that starts out with a blood test for genetics. And then if that's negative, they immediately contact the provider and the patient and say, now let's have the tissue. Let's go there now. Right? That's kind of an automatic process, so that no time is lost in maybe someone forgetting to order the next test, etc.
Got it.
So definitely that should be measured. Now, if that's negative, then it becomes a little more individualized. Whether you should go right to a comprehensive genomic test that looks for everything and anything, an aberration in every and any gene within the tumor. And I would probably argue, no, at that point, okay, when you are newly diagnosed, the main things we need to know to determine what's best in terms of treatment is your genetic status and your HRD.
Okay.
If you don't have that, that's okay. We can still treat you with the same drugs, right?
Absolutely. Yeah.
Still have a really good chance of responding to them.
Mhm.
It may be a little bit lower likelihood, but it should still work. Then if it doesn't, then we need to go back to the drawing board.
Mm.
Then we need
Okay.
to go back to the drawing board. And
Okay.
typically, I wait for a cancer to reoccur, analyze it again, biopsy it again, or whatever the circumstance may be, remove it again, and then analyze it, right? Because we'd like to know if we really have a cancer that unfortunately came back in spite of our very best treatments, what made that cancer tick? What made that one so different, right? That it became resistant to our very best treatments. That's the kind of question I would want analyzed in the lab,
Sure.
right?
Sure.
And at that point, a really comprehensive genomic assessment where they're testing for 20 to 40
Everything. Yeah.
pathways, and then you have a 10-20 page report. That is then worthwhile having in hand, because that can then really help that person who has a reoccurrence. They're the most in need of figuring out the next step, right? How are we going to treat you now?
Yeah.
Everyone knows what to do first, more or less.
Right.
But what are we going to do next? Now
Yeah.
that the cancer has come back, that's where, right, genomics can really help figure out best next step. Even clinical trial matching comes out of
Right. Right.
So that's where I think it's really, really important. And
Right.
yes, if that's not offered, right, if a patient has an oncologist who just says, okay, well, here's second line treatment, that's what the book says, this is standard stuff. Is that wrong? It's not wrong,
Mhm.
but could we do better? Possibly,
Better. Yeah. Yeah.
right? So at
Yeah.
that point, all that extra information would help us the most.
Mhm. Yeah.
Right?
One of the questions we have, or we encourage our patients to ask, is what tests will be done on my tumor? And so they'll know. And that's an easy question to ask. Yeah.
Yep, absolutely.
Yeah.
And
awesome.
Since most insurance companies, only
Yeah.
allow us to analyze, to genomically analyze your tumor about every 2 years.
Oh.
That to me is another reason not to, I don't want to say waste it, but not to perhaps use that on the very initial diagnosis. Because God forbid, if we're unlucky enough to have a cancer that's diagnosed, treated, and then recurs fairly soon, then you can't really get another set of genomic analysis if it's less than 2 years.
Okay, I was going to ask you, does insurance pay for biomarker testing? How does that work?
They typically do.
Okay.
They do, because they too understand that
Yeah.
really adds to the repertoire of treatment options and clinical trials these days. But they don't want to do it all the time, right? They don't want to say, oh, you just gave us this tissue 6 months ago, now you're giving us another lymph node, whatever, then they might not.
Okay.
And then that might be the time where I would really want to know what changes have occurred in this cancer after we've treated it with everything we have, and then it came back, right?
So it's a good tool in our tool belt, but knowing when to efficiently use it is key.
Right. So it just takes a little experience and knowing how that works and kind of what the payers allow us to do.
Great.
That's the safest way.
Great.
To do it. Yeah.
Great. We have, thank you so much for all this wonderful information. One of the questions that came in too that I thought was interesting, and maybe this kind of goes along with what we were just talking about, is if I have a recurrence, does my tumor get tested again, like the new tumor, or is it the original sample of the tumor? I thought that was an interesting question.
That is a really interesting question. And I love that someone is actually aware of that happening.
Yeah.
I see it sometimes where, someone might have a reoccurrence after 2 years. And then rather than analyzing the reoccurrence, for whatever reason, the doctors will pull the old tissue from first
That's been
diagnosis
stored. Okay.
and send that for analysis. And I don't agree with that.
Okay.
I don't think that's like water under the bridge, right? We
Got
want to
it.
know what's going on now.
Okay. So it's always the newer diagnosis. Got it.
Exactly. So again,
Okay.
Most of these tests are approved every 2 years. So I would really save them for that time of need, and then use the information to come up with the second or third or whatever number of treatment that you're looking for at that time, rather than, now today in 2022, we're going to analyze the tissue from 2020.
No.
The most
Good to know.
But I still see it done all the time. And
good to know. Yeah. Are there any questions that you can think of? We'll leave on this. Are there any questions that you feel a patient should have in their tool belt when they go and they want to ask about biomarker testing or genetic testing that you would recommend that they ask?
I think the most important thing that I encourage all patients, of course, out there to always consider clinical trial participation, right?
Yeah.
Any of the drugs that we have today, if it hadn't been for all you brave ladies that participated in the clinical trials to bring those drugs to the FDA over the last 10 years, right? That is how we move the science forward. And so if you are in that unfortunate position, right, where you have ovarian cancer and it has recurred, it has come back, that is the time where I would really encourage you to take a moment, right, and really say, I'm going to look at all my options. I'm going to speak to my doctor. I'm going to get my tissue analyzed, right? I'm going to want to see all the different treatment options, including clinical trials, right?
Yeah, of course.
I can pick what's best for me, right? In prolonging that journey, making it the best that it can be for me and my situation, my family, my lifestyle, my tumor, my everything. So I always think that's important. Sometimes
I think so too.
We're busy clinicians and we say, oh my gosh, I'm so sorry, your cancer has recurred. Here's what I recommend you do. Hold on a minute, you say. As the patient, you say, okay, that's very nice, but hold on a minute. I need some time to process this. Now, what do you say? What am I supposed to do? What do you think I should do based on what, right? And what are the alternative options, right? And sometimes that is also the time to say, let me get a second opinion. No one is ever going to be insulted. I know patients always think that, are you going to be insulted if I ask for a second opinion? Of course not. That is very much encouraged, right? I encourage all my patients to do so. I encourage anyone out there to do that, no matter where they're treating. I don't care if you're treating in the best hospital in the world, right? When a cancer comes back and some decisions need to be made, that is the time to really focus and say, let me consider all options. Let's put every card on the table, be transparent, get me all the information, right? Get me that tumor portfolio. I want a
tumor portfolio, yes,
of my cancer. Analyze this thing for me. What can we learn? How can we best attack this? What would you do if you were me? What would you do if I was your wife, your family? And let me ask a couple other people too,
Awesome. Yeah.
I want to say to all the ladies out there struggling with ovarian cancer.
Great. Great. Well, thank you so much for giving us more information and more clarity around the differences between genetic testing, biomarker testing, and why they are each independently important, not only in risk, but also in treatment guidance. And so I know it's a hard concept to digest for a lot of us. So any education and clarity that we can get, and thank you so much, is very, very helpful. We really appreciate it. We thank you for being here today. Yes. Before we wrap up, I just want to let everyone know that we are developing an educational animated video on genetic testing and biomarker testing that we hope to have delivered sometime in September. So we'll be sure to promote that all to you, because I know that these concepts can be hard to understand. So any kind of visual animation, at least for me, I'm a visual learner, can help us learn more. So that will be coming out soon. But we just want to thank you so much for putting some insight to this hard to understand topic for us. If you are joining us today, we would love for you to please complete this survey, which you can find in the chat for us, and let us know if you enjoyed the session. And thank you all so much for joining us today, and we will see you next month.